my first question to our panelists and speakers would be the following. We've all heard and talked about how important it is to evaluate pain and functional disability and improvement in both of these domains for finding a new treatment and a good treatment for symptomatic relief of osteoarthritis. As was alluded earlier by our speakers, the most commonly used instruments for these manifestations are the Western Ontario and McMaster Universities Index, also known as WOMAC, or various numeric rating scales. So my question would be three-dimensional, and you might want to pick and choose whichever aspect you would like to highlight in your responses, because I recognize that all of our panelists and speakers come from different backgrounds. But that's the beauty of it, because it's everyone's collective experiences that make it so rich in promoting the discussion. So the first dimension of the question is this: what other symptoms or signs or manifestations of osteoarthritis you think would be important and worthy to capture in clinical trials evaluating novel products for OA? So that's the first. Second is, if you were to talk about manifestations, maybe other than the pain and function or pain and function, mention if other instruments besides the WOMAC and NRS and others that Rob showed on his slides that are frequently used as secondary endpoints, other instruments that may be helpful and again important and worthy to evaluate in clinical trials for OA. And then the third dimension, again, if you're talking about signs and symptoms, manifestations, instruments, talk about how long you would think the evaluation need to be done for, how long we should be monitoring our patients. So let's maybe start with Tuhina, if you could. If you could, start warming up the discussion and leading us into these different aspects of OA product development.
Sure, thank you. And before I dive into that, all of those questions, I should point out that the Q&A that the attendees are submitting their questions to, that we will be getting to those questions in a few minutes. We were just doing a few warm-up questions, but yours is a big one. So I think, I don't know that I remember all of the elements, but I'll start with duration. So we know that osteoarthritis is a chronic disease, and trials of just 12 or 16 weeks is, from a clinical perspective, it's helpful to see that there can be relatively short-term improvements in pain, and patients do value that. We did hear that strongly from our patient panel when we developed the ACR-AF osteoarthritis treatment guideline, that even such short-term benefit is important when they don't have many other options. But ideally, we do need to see the longer term durability, as Dr. Hart mentioned as well. And the concern about that is it's unclear whether or not the instruments that we do use, such as WOMAC or NRS, et cetera, are fit for purpose for much longer term trials. And as I mentioned, and I think there will be other speakers later today, so I don't want to steal their thunder, but I really do think that we have to strongly consider how patients, how individuals think about their pain over a longer term period of time of years that many trials are now embarking on or have embarked on, when they're also trying to establish structural endpoint improvements. Because what someone considers as a certain pain level today, 2, 3, 5 years from now, they have a frame shift in how they anchor their pain. They've maybe changed their functioning. So there has been discussion, and there are some proposals for a pain per unit of activity, such as walking, or pain per unit of function, as one possibility of trying to address that. Another question you asked was about other instruments, and it's really challenging to address that head on without having many other instruments formally tested in trials. And we know from some existing trials that average daily pain can have a slightly different signal than WOMAC pain, than NRS, et cetera. And so I think it's very challenging for a sponsor to a priori choose something at a primary endpoint of 12 weeks where one of those outcomes meets statistical significance, but the others do not. So we do understand that pain is very multifactorial, and a single unidimensional instrument may not be sufficient to capture all of that. David Felsen has published on a pain related to a nominated activity, so something that a patient, an activity that a patient feels is important that contributes to pain, and in a relatively short-term trial has shown that that had a bit more sensitivity to change than some of the other traditional instruments. And I'll pause there and allow others to jump in and address some of the other aspects.
Great. Thanks, Dr. Neogi. Maybe Dr. Tive could continue the discussion.
Can you hear me?
Leslie? Yes.
Okay, good. So I just want to say first that although I do work for Pfizer, the views that I'm expressing today are my own and don't necessarily reflect the views of Pfizer. But I have a couple of things. I mean, such a comprehensive answer by Tuhina, but I have a couple of things to add to that. First of all, the whole duration of study is an important thing. I mean, we need to look at long-term safety, but sometimes efficacy does not get measured appropriately over that period of time. And I think that's something that we really need to look at and to try to solve. And I don't think we're there yet. And hopefully some ideas today will come up to help us with that. But I think, we do need long-term data, but sometimes it's hard. But I also think that there's a couple of things that we need to look at that we don't necessarily look at in trials of OA. And one is that the way patients process pain is very important, and different people process pain in different ways. I know Tuhina's done a lot of research on this. And so using things like the widespread pain index or the central sensitization index might be helpful to us, because you want to assess the degree of processing differences between people, and that might be at some point a tool for really predicting who might be the best candidates for joint surgery, and people having different outcomes from that. Having said that, I do think that neuropathic pain should be part of what we assess using a pain detector, an ID pain or the LANS, so to look at that also. And Dr. Felsen also published a paper in 2018 looking at different composite endpoints to see what, in addition to WOMAC, WOMAC pain and function might be useful. And I think that he found that stiffness was pretty sensitive to change. So we don't usually look at that, even though we measure it. There are things that we measure in our studies that we don't necessarily look at. And so that's one of them. And then the other one is rescue medication, to really keep track of that. So that would be my answer.
Thank you. Thank you, Dr. Tive. Excuse me?
I'm sorry, Dr. Lapteva, I was going to comment.
Please, Mr. Agee.
On some of the medication. So I try to follow a lot of the technology trends within my industry and other industries, but one that captured my eye was for people that were experiencing problems with pain or with similar arthritis drugs. And there's a company that's supposedly out there looking at making blister packs that work interactively with your phone through a Wi-Fi connection. And when you go to open that blister pack, it will actually log through your phone when you go and take one of these medications. And I wonder, or I was hopeful that if something like that could be accomplished, and you could collect those metrics associated with how often, say, a trial group went to that blister pack, it's logged through their phone, if then you could run different models, analytic models, to determine when a person was taking that medication or when they needed it the most and how often they were taking, but several different factors associated with that type of technology.
Thank you. This is very helpful and quite practical. Thank you. If Dr. Jacobs could add to the discussion.
Absolutely, and thanks for having me. Really excited to be here. And Mr. Agee, I just want to say that important activity of going to the car shows, I fully understand how important that is. My dad has a couple of classic cars, so understand what goes into getting the car all dressed up for the show and actually being there. So that makes sense.
A lot of work. Thank you.
Mm-hmm. And then just kind of build on what Dr. Neogi and Dr. Tive had mentioned about pain measures. Certainly agree that it's important to capture other things that can influence pain, because we know pain is so individual. And not only pain detect, to really look at neuropathic pain. And I think Dr. McGuire had mentioned something similar to that in the Q&A box, but also looking at depression. So I think some great work that has come out of the Arthritis Foundation was that more than 2/3 of OA patients report feelings of depression or anxiety over the past 7 days. And we know there's an inherent connection between, between pain interference and pain severity with depression and anxiety. So I think it'd be important to capture those moving forward, to include those as covariates as well. I think some other interesting measures, one of the intriguing things that has come about from the pandemic is our ability to remotely monitor patient function. So I think we were it forced our hand a little bit last year, but being able to assess some functional measures like the 5 times sit to stand, something you can do remotely via Zoom, just like this, or to measure stiffness, as that was brought up as another important factor. We can look at range of motion remotely as well. So I think it's embracing some of the technological advancements and helping capture both improved measures of pain and function.
Thank you. Thank you.
If I may just add to that, I do think, sort of coming back to this multifactorial nature of pain, I think one of the concerns that we have to tackle is, as Dr. Tive was mentioning, is that concept of phenotyping and pain mechanisms. And this is sort of an interest and passion of mine, but in addition to questionnaires, there are some very simple objective measures such as handheld ergometry. And I think, one of the concerns about trials, again, if we have this one size fits all of anyone who has a certain level of pain, and if they have osteoarthritis, they're in the trial. But if we do not disentangle what's the major contributor to their pain, if we cannot identify OA as being the major contributor to their pain, then the treatment target may not be able to show its efficacy when their pain is primarily being driven by numerous other factors. So depressive symptoms is important, sleep is important. And then I just want to also make one small note about this concept of neuropathic pain. I think the IASP has recently published their definition of nociplastic pain. And I think a lot of what we're talking about here is nociplastic pain rather than neuropathic pain, because we actually haven't demonstrated objective evidence of neuropathy in OA. And so some targets may affect nociceptive pain, nociception, and others may be more nociplastic. And so really getting at phenotyping will help provide us ability to find that signal for the, weed out the noise and get that signal to show efficacy.
Thank you. Thank you for these very valid comments and valid points. Thanks. So Dr. Shibuya, if you have a couple of words.
So I would have to say, I'll start out by saying it's been very humbling listening to the conversation. And I feel like a pointy-headed bureaucrat and very much not in step with the current thinking. But I did want to defend why we do the things we do a little bit. It is very difficult to conduct like a placebo-controlled long-term trial. There's a lot of patient dropout. With a lot of the longer trials, we can't get very interpretable data. So that's one reason why we tend not to conduct very long, at least placebo-controlled trials. As you know, when we were looking at the toxicity of NSAIDs and COX-2, we did run long cardiovascular outcomes trials, but those were always active controlled. The safety is more difficult to understand, and obviously you don't get a lot of conclusive efficacy data out of that. So that's one thing. With regard to the endpoints that have been discussed, I think we in our division, I think, are willing to look at anything. Like, one thing that I see once in a while on typically on phase 2 OA protocols now is actually actigraphy. And I am very curious to see what that's going to show, because I am aware that some patients might actually, their pain might be the same at baseline as it is at the end, but they were more active. And so their quality of life is better. So I'm very interested in seeing a lot of these other things, but the focus has always been very much on, in the philosophy in the division has always been that sponsors need to demonstrate an effect on pain. They didn't want it to be confounded with other things that had gone. I mean, our old 2 division directors ago, I had this discussion with him. He didn't want us to be making decisions because somebody won the lottery, and when they went in for their visit, they reported less pain. So it's very interesting. Thank you for all the conversation and all of the comments. It's always so important to hear the patient perspective. And so I'm obviously, our management is on the call, and so we will take all of this back. But I did want to explain that is why my presentation, we sound so rigid and old-fashioned, and like we're not aware of what's going on. We are. It's just hard for us to change. And like we're stuck with the WOMAC because that's considered a validated endpoint in OA trials. And so therefore, in order for regulatory decision making, that's kind of what we're stuck with. Thank you.
Thanks, Rob. Very well said and well explained. Yes, Tuhina, please.
Highlight a comment that David Felsen has put in the chat. And I think this goes back to trying to combine pain with per unit of function or activity, and a similar concept to the pain with a nominated activity. In the chat, he's written, what about using activity-induced pain? For example, having a patient walk a distance and gauging their pain at the end of the walk, or having them go up and down stairs and seeing how many they can climb before pain. So the concept of movement-evoked pain, which I think is really attractive when we're thinking about OA being a large part of the pain being mechanically driven and activity driven. And so that might help us get more specificity on the pain response to try to tease out some of the other contributors to pain. So, I think these are all, we're talking about a lot of interesting ideas, and we just have to have proof of concept with validation in the setting of clinical trials. So we do need sponsors to include these measures and report them out so we can understand how well they actually perform.
Thank you. If Dr. Hart could also add to the discussion, if you'd like to.
So I'm going to just reiterate a couple of the points that have already been made, because they've been so well articulated by the other members of the panel. But basically, I think what you've heard from me during the presentation, and I think you've heard, is that we are willing to be flexible, but from a regulatory perspective, we do need that level of evidence. And so again, providing the details and going through the path to validate additional endpoints and tools. We're definitely open, but we do need that validation. And then the other part of the question that we haven't spent as much time on is that duration. And again, from our perspective, it really does depend upon the biologic product and the mechanism of action for those products, and so taking that into account.
So there is a question here that maybe we can bring Mr. Agee into this conversation about, from a patient perspective, the importance of structural improvement leading to long-term symptom relief. And I think a lot of conversation has been about whether or not a new drug may improve the structure and reduce disease progression, but that it might take some years before that translates into symptom improvement over someone who didn't, wasn't on that drug and didn't experience that structural improvement. Do you think from a patient perspective, someone would be willing to take a medication for some time that may not provide immediate symptom relief? Oh, so I see your expression, but you're still on mute.
My apologies. Yes, absolutely, without a doubt. If I could, if I could take a drug for a long term to determine whether it was going to have structural benefit and not degrade any of the other joints, cartilage, tissue to my joints, I would definitely consider it. That trial, absolutely.
Thank you. Do you think that given that it wouldn't be providing symptom relief immediately, how would you feel about having to take yet another medication for the symptom relief in the interim until that other agent may provide symptom relief down the road?
I don't have a problem with that. Anything that I could try to help alleviate, my pain or somebody else's pain down the road through testing of medications, I think it would be an excellent choice, and I would be willing to do that, yes. And I think a lot of other patients would as well that are dealing with osteoarthritis.
All right, I have a question for the panelists, and there are many questions here, and I apologize in advance if we can't, and obviously it would be probably impossible to capture all of the questions that are here in the box. But there is one issue that's often associated with clinical trials, developing products or testing products for osteoarthritis, and that's the heightened placebo response. And so the question here, what are the panel's thoughts about the increased placebo effect in pain trials, but also in general in trials with osteoarthritis?
I can try to start out. We're writing a paper now on placebo response in osteoarthritis trials. So I've been thinking about.
So right up your alley.
I've been thinking about this topic a lot. And I think that what we really need to do is to, what we do is we do trials and we have a placebo response, and often it's quite large, and often it's very hard to show a treatment difference because the placebo effect is quite large. And then we go back and we try to look at what types of patients have the biggest placebo response. And we look at things that are known to sort of drive placebo response. Sometimes it's ethnicity, sometimes it's sleep, sometimes it's history of pain, sometimes it's failed medications. And we sort of go back and we look at that post hoc and try to figure out what might have driven this. And I think what we really need to do, and I think it's been said before, is we need to sort of prospectively make sure that we have a group, and sometimes we don't have enough patients to really look at that. We don't have enough patients in a specific group, and a psychiatric disorder group, for instance. So we have to really try to enroll in our studies patients who are diverse enough so that when we can really try to understand what's driving the response instead of going back and trying to look at it after the fact. I think that's one thing that could really sort of help us. And I know that ethnic diversity, for instance, in clinical trials is a big topic now. It came up a lot during the vaccine development. And I think that that's something that we really have to keep top of mind so that we can go back and look at what might drive placebo response and make sure that that's represented in our trials so that we can measure it.
Thank you, Dr. Tive. Thank you. So there is one more question here, but that also constellation of questions. They're somewhat related, so I try to group them. And they are about the discrepancy between disease severity, the ability to modify the disease, and pain and symptomatic improvement. So that, and the question is, how do we reconcile these when pain and function may be improving, but there is no real change that we're seeing, or maybe even progression, say, on the imaging studies. And that brings the entire issue of discussing what we consider to be disease-modifying osteoarthritis drug. What kind of product and what kind of properties would be considered disease-modifying? What would be the important parts to consider when we would like to really change the disease progression and maybe regrow and regenerate cartilage?
Jump in if that's okay.
Yes,
so
please.
I think I would have to agree with some of the information that Dr. Hart had presented on both highlighting pain and function as primary outcomes, but also including structural outcomes moving forward. But I think if you just look at pain and function, you're going to see that there's just different mechanisms involved when compared to structural changes over time. So I think you really have to try to identify treatments that can address both structure and pain. And I certainly understand the challenges with drug development, especially with pain, since we've seen recently that pain relief is greater with, you see a greater placebo effect with saline injections in terms of pain relief than you do with WOMAC function scores or actual functional improvement with other tests, functional tests. But I think you really have to include the structural component as well. And I think what's definitely challenging from a drug development standpoint is that, as Dr. Neogi and Mr. Agee brought up, was that you may need combined therapies to address multiple mechanisms. So is there a way moving forward to have an avenue for a treatment protocol instead of a single treatment drug to address everything?
Thank you. That's a good point.
And I do want to just highlight that there is this so-called structure symptom discordance in osteoarthritis that's well recognized, but it really is reflective of the fact that pain is multifactorial. And so if you do analyses where you really adequately control for all of the differences between people that could contribute to their pain experience, there is a very nice, strong linear relationship between structure and function, structure and symptoms. And so this again highlights why we really do need to have better phenotyping, better pain phenotyping, to understand what's contributing to the overall experience of pain, and that when you're enrolling them and you've got a treatment target, that it's fit for purpose. Like the study sample is actually the people that would benefit from that. So you can see the signal despite potential noise. And so again, I would advocate for trying to obtain better objective measures to understand what's contributing to their pain. And you know, we know that without disease pathology, you wouldn't be leading, going to end stage disease and going to joint replacement. So what structural measures can we use to get disease modification approval? And I think some of the next sessions will be addressing that. There were a couple of questions here for Dr. Hart about sort of how is clinical meaningfulness defined or understood by FDA, and durability of treatment effect, given that many pain management options lose efficacy after some months.
Yes, so as far as what is clinically meaningful, I think we've heard very nicely from the patients this morning that, you know, people define what's important to them differently, but there's some common themes and threads that we continue to hear. And so we want to make sure that we're not particularly given the risk of a lot of the products that we regulate are not looking at something that's providing something that's statistically significant because there was such a large number of people, but you know, it's 2 points on a scale such that, you know, out of 100, such that that doesn't represent any change to that patient's life. And what we want to make sure of is that we're seeing something that clinically matters. And so we often have sponsors predefine what that is based on the scale that they're using, based on their product, based on the mechanism of action. So again, not a one size, but it's what we're looking for is to make a difference in patients' lives. And so we want to make sure that that's something that actually matters to patients. And so what that difference is on something like the WOMAC will differ compared to another instrument or endpoint. Again, we've talked about being flexible on what are other possibilities, but that's sort of the gist of what we're getting at and what we're looking for. And then there was a second part to your question as well.
Durability. So the concern is that often management of pain, the options that are available lose efficacy after several months. And so how does the agency think about that?
So again, it's not a one size fits all. It will depend upon the risks associated with the product and the population that's being targeted and what the indication for that particular product is. So basically a product that could be changing the function and structure may have a longer period of time where you'd want to see something when you look at pain and function. Again, you know, we know that a lot of these products are being given intra-articularly or surgical. We know that there's going to be a potential acute increase in pain. We want to make sure that that benefit, particularly from a product that cannot be repeatedly administered, is sufficient to outweigh the risk. We're constantly looking at this benefit risk framework. So again, not a one size fits all approach, but those are some of the considerations that we have when we look into this.
Well, we are a bit over time for this first session. There are a number of questions in the Q&A that have not yet been addressed, but some of them will be addressed in some of the subsequent sessions. And so we'll invite panelists to look through the questions and address them as they think is appropriate for their area of expertise, and we'll rely on the subsequent sessions to also touch upon some of these. So I'd like to thank each of the panelists and speakers this morning